This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neurology titled Preoperative Imaging Evaluation of Primary Trigeminal Neuralgia using 3D TOF-MRA and 3D FIESTA-c, a retrospective study of 412 cases.
This is a substantial cohort, Alara. 412 patients is a significant number for a study focusing on the nuances of neurovascular conflict. For our residents and colleagues listening, we know that primary trigeminal neuralgia, or PTN, is one of the most debilitating pain syndromes we treat. The hallmark is that recurrent, stabbing, electric shock-like pain.
Exactly. And as the paper notes, the pathophysiological mechanism we are hunting for is chronic pulsatile compression of the trigeminal nerve, specifically at the root entry zone, or REZ, by adjacent vessels. This leads to focal demyelination and that abnormal neural excitability we see in our patients.
And that's why microvascular decompression, or MVD, remains the gold standard. But a successful MVD starts in the radiology suite, not just the OR. We need to know exactly what we're walking into. This study by Huang et al. Really dives into how we use 3D time-of-flight MRA and 3D FIESTA-c to get that roadmap.
To set the stage, the researchers looked at patients treated between January 2017 and October 2025. It's a classic demographic: 248 women and 164 men, mean age around 63. What I found particularly rigorous was their methodology. They didn't just look for, is there a vessel? They used two distinct criteria for diagnostic performance.
Right. First, the binary identification, simply the presence or absence of a responsible vessel. But the second criteria is what really matters to a surgeon: complete concordance. Does the imaging correctly identify the specific vessel type that we actually find intraoperatively?
Let's talk about the imaging sequences themselves for the residents. They used a 3.0 Tesla scanner. For the 3D FIESTA-c, which stands for Fast Imaging Employing Steady-State Acquisition with Phase Cycling, they used a TR of 6.4 milliseconds and a TE of 3.1 milliseconds. For the 3D TOF-MRA, the TR was 12 milliseconds and TE 2.9 milliseconds.
It's worth noting the strengths of each. The paper points out that 3D TOF-MRA is excellent for depicting responsible arteries because of the high signal intensity of flowing blood. However, 3D FIESTA-c provides that high-resolution visualization of the spatial relationship between the nerve and the vessels. It's that water excitation look where the CSF is bright and the nerves and vessels are dark.
But each has limitations. The paper mentions that if you only use one, you might miss low-flow vessels, venous compression, or struggle with multiple vessel involvement when the local anatomy is crowded.
So, what did they find when they opened these 412 patients up?
Intraoperatively, responsible vessels were identified in 407 out of 412 patients. That's 98.79%. Only 5 patients had no identifiable responsible vessel. The superior cerebellar artery, or SCA, was by far the most common culprit, found in 250 cases, which is about 60.68%.
That tracks with our clinical experience. But look at the complexity. The second most common finding was a combination of the SCA and the petrosal vein in over 13% of cases. That's where imaging can get tricky.
Exactly, and this is where the results for the combined imaging really shine. If we look at the binary identification, just is there a vessel, 3D TOF-MRA had an accuracy of 90.53%, and 3D FIESTA-c was at 91.99%, but when they combined the sequences, the accuracy jumped to 96.36%.
That's a significant jump. The Cochrane's Q test showed a p-value of less than 0.001. But let's look at the complete concordance rates. This is the real test of an imaging protocol.
This was the most striking part of the study for me. When trying to match the exact vessel type found in surgery, 3D TOF-MRA alone only had a matching rate of 74.77%. 3D FIESTA-c was better at 82.77%, but the combined approach reached 87.86%.
And the kappa values support this. For those prepping for boards, remember that kappa measures agreement. The kappa for TOF-MRA was 0.531, moderate agreement. FIESTA-c was 0.702, but the combination hit 0.786, which is much stronger.
The paper also did subgroup analyses. In the SCA and anterior inferior cerebellar artery, or AICA subgroups, the combined approach significantly outperformed either sequence alone.
Why do you think 3D FIESTA-c outperformed TOF-MRA when looking for concordance?
The study suggests it's the spatial resolution. Because 3D FIESTA-c provides such a clear contrast between the CSF, the nerve, and the vessel, you can see the actual point of contact or distortion more clearly. TOF-MRA is great for the what of the artery, but FIESTA-c is better for the where in relation to the nerve.
And don't forget the veins. TOF-MRA is notoriously poor at picking up the petrosal vein or other small venous structures because the flow is too slow to generate that bright signal. If a resident only looks at the MRA, they might tell me it's an SCA compression, and then we get in there and find a large petrosal vein also pinning the nerve. That changes the dissection.
That's a great point. The paper highlights that the combined approach is especially helpful in those cases of venous compression or multiple vessel involvement. It essentially allows for multiplanar reformation, or MPR, and maximum intensity projection, or MIP, to be cross-referenced.
I think the takeaway for the surgeons listening is the importance of not relying on a single sequence. This study of 412 cases, a very robust sample, shows that the combined evaluation of 3D TOF-MRA and 3D FIESTA-c improves preoperative assessment with higher diagnostic accuracy and better agreement with what we actually see under the microscope.
It really emphasizes that for surgical planning and intraoperative orientation, we need both the arterial detail of the TOF and the anatomical relationship provided by the FIESTA-c.
Absolutely. It reduces surprises in the posterior fossa. If we can see that it's an AICA or a combined SCA venous conflict preoperatively, we can tailor our approach and our expectations for the decompression.
Any final thoughts on the study limitations mentioned?
Well, it was a retrospective study, and as with all imaging studies, there's an element of observer dependence in interpreting these sequences. But given the high correlation with intraoperative findings, the evidence is quite compelling.
Agreed. It's a clear call for standardized high-resolution neurovascular imaging in the workup of PTN.
Well, that's all the time we have for today. Thank you, Dr. Alara, for breaking down the data.
My pleasure, Dr. Aris.
To our listeners, keep diving into the literature, and we'll see you next time on the Neurosurgery Hub podcast.